questions. Let's take questions on these two talks. Yeah.
All four.
Do we have a microphone?
Thank you. I have a question to Dr. Shen. As you say, these are primary open-angle glaucoma patients, but the demographics show that they are the normal tension glaucoma patients. It puts, I think, a big bias in this study. In the chronic open-angle side, you have a very high pressure. Why don't you choose people with primary open-angle glaucoma and high pressure? Because as we know, the normal tension glaucoma, although it's a subtype of primary open-angle glaucoma, have different visual field characteristics, more in the central field, maybe some different OCT characteristics. So how can you
Right, thank you for bringing up that question. So I think the issue is when we're looking at primary open-angle glaucoma, it kind of exists on a spectrum. And more we're more defining the subtypes of primary open-angle glaucoma based on optic nerve and visual field characteristics rather than just basing it on intraocular pressure alone. So we didn't select patients based on their intraocular pressure. In fact, we just recruited, the patient that came into clinic and they happen to have a more low tension profile. But I understand your comment, and I think that there may be differences, but I don't think the intraocular pressure is the way to separate the categories.
Yes, but with the high intraocular pressure primary open-angle glaucoma, you can maybe still have more laminar holes. You can't
It's hard to know because these are not laminar holes; these are in the prelaminar tissue.
Yeah.
So you're right, but it's hard to know if those intraocular pressures are high enough to cause axonal damage directly.
Thank you.
Thank you.
This is a question for Don.
For me?
Yeah.
No, let's save that. Let's, if you don't mind, let's just make sure that these two speakers get their chance.
Okay, so then back to these holes. In the past, I think this is probably correlated to what people call Schnabel's cavernous atrophy, right?
That's a good comment, and I think we did look into that. And some of that was also talking about vitreous being pushed into the lamina cribosa, and these are more primarily in the prelaminar tissue.
But there's the really original description of Schnabel's cavernous atrophy is holes in the optic nerve related to high pressure.
You're right.
And it's an atrophy. But it's also been described with vascular disease, but it's primarily described with high pressure. So I think that question about pressure is pretty germane to that, if this is what you're looking at is Schnabel's cavernous atrophy.
Right, and you may be right. And we did do a multivariate analysis to look at if high intraocular pressure did directly affect the presence of holes. And at least in our study, we didn't find a direct link between the maximum pressure and the presence of holes.
But that laminar degeneration process is a critical component of the glaucoma process. So that laminar degeneration can occur as a laminar hole, which is really just a degeneration, or a laminar tear,
Sure.
Where it dehisces from its insertion on the pia or on the sclera. And when that laminar structure collapses and you get microvascular rupture, we see that as a disc hemorrhage. And it's directly correlated, I think, to the laminar disruption. And that's what's causing the disc hemorrhage. That's its etiology.
We were talking about the holes inside of the nerve tissue itself, not in the lamina.
Yes, and actually it was interesting that in her case, in the chronic angle closure patients, they did have higher pressures.
Yes.
And the histologic example you cited was a secondary elevation pressure.
Yes, exactly.
So it's all consistent, I think,
Yeah.
your comment and her presentation.
And I do want to mention that one potential limitation to the study is that it's possible gliosis can take place and potentially fill up some of these holes, and we may not be able to image them all with sweat source OCT.
Yeah, I was going to get at that, because the implication of what you were saying is that maybe this was a different process involved. Perhaps the process is the same in both groups, but because it occurs suddenly, you see the holes.
Right.
And if it occurs over time, you have time for those to collapse
You may be
down
right.
and have the thinning that's more characteristic of glaucoma.
So I think a more longitudinal study may answer some of those
Is there
comments.
somebody? Other question? Yeah.
I'd like to ask questions to Dr. Liebman. Thank you very much.
No. Because we'll do that later. I want to make sure we focus on these two. So while you're thinking about questions for two recent speakers, let me ask you two questions. one is technical, one is more general. The more general question is, do you think that the change in blood flow to the lamina cribrosa is going to be a more sensitive early indicator of early glaucoma than others indicators? Is that a possibility, or?
Yeah, but in some patients, I think it's okay because the glaucoma is multifactorial disease. If intraocular pressure is a major cause, maybe vasculature is the secondary effect of vascular degeneration. But the patient has Framar syndrome and lowering blood pressure. In such case, maybe primary vasculature was degenerated first, and then to form the other sequential glaucoma phenomena. So that case, blood flow is very early, good phenomena to detect, to differentiate glaucoma and normal.
Did you want to comment on that
Well,
before I ask my
I mean,
technical question?
it's an interesting question. So when we think about glaucoma in a modern sense, we've talked very little about intraocular pressure. We talk about it as a risk factor and something we treat. But if we're talking about technology, the application of technology, whether it's blood flow or structure, we're really just looking at, we're not thinking about those other aspects of disease. They're all just added risk to it. I don't think we can discern various types of primary open-angle glaucoma from one another. It's based upon your point. Whether it's POAG or NTG, whatever that is, we cannot discern that difference on an image. Right. And it's just all part of the glaucomatous optic neuropathy process.
So technical question. When we've measured the thickness of lamina cribrosa, and it's very easy to see the vitreal surface, the interior part. It's much more difficult in some cases, yeah. So can you give us some sense about how often you're guessing or,
Yes,
or how you solve that problem?
Yes, actually I agree because I search many patients, maybe 30% patient can visible lamina cribrosa.
What percent?
30%.
30%.
Can visible lamina cribrosa with even SSOCT. Of course, SDOCT is almost impossible to find that.
Right.
So, but generally, large cup and thin the lamina tissue, pre-lamina tissue, that case we can easily to detect very beautiful lamina cribrosa.
Right.
So maybe I have some bias, selection bias to doing this type of research.
Right.
When we did EDI-OCT, it turned out that the mean deviation on the field of those patients was like -8, because you had to get rid of all the tissue in order to be imaged, in order to image the lamina.
Question. Lucy, okay.
She has one.
Yeah.
Thank you so much. I have two questions. The first one is for Dr. Liebman. And I...
Okay, go ahead. I give.
Did I say wrong? Did I say wrong? Ask questions two. Okay,
Welcome.
so I'd like to
Yeah.
start questions to Dr. Nakazawa.
Ah, great.
Yeah. And your talk with beautiful imaging of laser Doppler flowmetry and OCT angiography was beautiful. And in laser Doppler flowmetry, blood flow decrease disturbance is seen a little diffusely in the optic nerve lesion. But in contrast, MB defect, microvascular defect, is seen sectorial, and probably it corresponds to the site of laminar defect. So how do you explain differences in diffuse circulatory disturbance shown by laser flowmetry and sectorial vascular defects in OCT angiography?
So when we measure the temporal blood flow, that we can beautifully detect a decrease in myopic patient with decrease in visual acuity. But the standard glaucoma, if the vessel was overlapped and the tissue area is very narrow, that case is very too hard to show the clear difference, sectorial difference. So when the resolution of laser spectroscopy is very low compared to OCT angiography, but we can detect the average of lowering blood flow very early time point of glaucoma. So we, mix together the information helpful for clinical situation. That we are
So
now
you
using
trust-
like that.
You trust OCT angiography more.
Thank you.
And
Yeah, I'm sorry, go ahead.
Yeah, and the second question is that probably Dr. Liebman said that disc hemorrhage is caused by destruction of vascular structure of the lamina cribrosa. And I'm a retina specialist, but I completely agree with that. But disc hemorrhage is usually seen on the surface of the retina, and the lamina much superficial than the laminar level. So if the hemorrhage first occurs at the laminar level, why it is observed on the surface?
Did you want to answer that? Or do it- you?
So of course, the nerve, the axons are passing through the lamina. So as the microvascular rupture occurs, the blood then comes along the axonal path with the axons towards the retina, and then sits on the surface of the optic disc at its border or just inside the disc. So we see it move forward, towards the eye, and that's why it has that characteristic flame shape that is in the nerve fiber.
Yeah, okay. In our highly myopic patients, sometimes at the site of laminar defects, nerve fiber layer is herniated into the defects, and then RPC is also sucked into the laminar defects, and vascular RPC vessels disrupt. I see such cases, so I was wondering if some of the cases were disruption of RPC secondary to herniation to laminar defects. It's a comment. Thank you.
Thank you. One more question, then we'll move on. Did you look at the location of the defects around the disc in the two groups? Did that differ at all?
So the holes that we found in the CACG group,
Yeah.
they're often nasal. So they're not totally corresponding to where the visual field loss is geographically. But the one histology study also described that many of the holes they found, or many of the hydropic degeneration, was either nasal or central. So again, kind of going back to the comment, there probably is gliosis and atrophy that's taking place, and that may be manifesting at the visual field loss.
Thank you for these lovely presentations. I would like to ask, our main problem as clinicians is early detection of open-angle glaucoma, or to differentiate between glaucoma suspect and actually glaucomatous patient. So what is the most useful investigative tool do you use? Is it field, OCT, blood flow? And actually, I'd like to say that ocular blood flow by OCT angio, and according to Topcon, until now, yet we don't have definitive measures. Actually, I did a paper long ago, and I measured the peak systolic volume and diastolic volume and the resistivity index in glaucomatous patient, and actually they differed from normal patients. So until now, I don't have a definite measurement for the ocular blood flow according to age to different glaucomatous patients. Thank you very much.
Clinician.
Yeah. Did you want to say something about just the blood flow? Because the general question is an excellent one. I'd like to come back to that after all the talks are over and ask about early detection and what test one uses.
Sure.
But did you want to speak to the blood flow part?
Yeah, just a comment about the blood flow part. I think some of the publications that have come out have compared the diagnostic capability of OCT angiography versus nerve fiber layer thickness, and it seems like that it's not superior to the structural measures, at least based on the publication that's out.
Okay, thank you.